DIEP flap breast reconstruction is where we take the tissue from the abdomen and take it off and then reconnect it to the chest under a microscope. It could either be done on one side or both sides. The risks of the procedures, beyond the general risk of bleeding, infection, wound complications, there is the risk of flap failure. The risk of flap failure is less than 1%. You are going to be in the ICU, the intensive care unit, for usually 3 days. You're not sick, you're wide awake. The reason is for monitoring purposes. What will happen is when you wake up, you'll have skin on the outside that's sutured in from the abdomen, and there's a probe that measures the tissue oxygenation. That probe is wirelessly connected to our phones. The nurses get notified and we get notified if there's a change in the tissue oxygenation. And if there's a concern, if there's an issue, sometimes we'll have to take you back to the operating room to take a look and see what's going on. So although the failure rate is less than 1%, the take-back rate is about 7%. The 95% of all of these issues occur within the first 48 hours. That's why you're being monitored so closely. But if there is the risk of failure. If there's something that happens during the operation where we're concerned and we cannot get the tissue to blood supply to work, and we may have to just remove the flap and put a tissue expander back in. But that is exceedingly rare for that to happen. There is a risk of a fluid collection, which is a seroma. There's a risk of a hematoma. Again, you're going to be in the ICU for the first few days, so all these things will be monitored closely. You're going to be on a blood thinner when you go home. You'll be on a blood thinner in the hospital, and then when you go home, there's a risk of clotting. So when you get home, make sure you get up and walk around. There's a risk of something called a pulmonary embolus, which is a clot in the lung. If you notice any swelling in the legs, usually it's one leg, but it could be in both legs. Or if you notice any sudden onset of shortness of breath, which you'll know that something's not right. This is very rare when you're on the Eliquis, and especially when you get up and walk around. With the abdomen, we're gonna close the abdomen. We're gonna reinforce it with something called Phasix mesh. Phasix mesh is an absorbable mesh. It gets replaced with scar tissue over the course of about 18 months, and it's to reinforce and tighten the abdomen. Even with that, there still is the risk of something called a bulge or a weakness in the abdomen. Sometimes we have to go back in and put new mesh in to tighten it. Risk of scarring is 100%. You'll have scars. There is a second stage that is generally done. There's skin that's left on the outside during the first stage, usually at the bottom. And then at the second stage, which is usually 6 months later, it's an outpatient procedure. We go in, we take out the skin, we close it and we reshape it. Sometimes we'll do fat grafting either from the sides or the back to add volume. Sometimes we'll do liposuction to remove the volume. There's a risk that the nipple and the areola have wound complications. Sometimes we have to reconstruct that at the second stage. And then lastly, there's a risk of something called fat necrosis. Fat necrosis is where parts of the flap survives, and parts of the flap aren't as happy with the blood supply they're getting. So sometimes you can get areas of firmness or hardness, and at the second stage we'll go in and we'll remove those, and if we have to, we could fill it in with fat grafting.